Welcome to the ASG Video Tips Series. I'm Dr. Chris Thompson from Brigham and Women's Hospital, and I'm here with our Advanced Endoscopy Fellow, Dr. Allison Schulman, who's going to tell us about a case of a gastric bypass patient that highlights normal anatomy.
So this is a 29-year-old woman who had a Roux-en-Y gastric bypass 3 years ago, and she had one episode of abdominal pain that led her to another hospital. She underwent endoscopy at that hospital and was told that she may have a small ulceration, and she presented to see us in clinic a few months following that procedure. She requested a repeat procedure just to confirm healing of the ulcer.
Here we are passing the endoscope down the esophagus. When we pass through the gastroesophageal junction, we enter into the gastric cavity, which was divided and separated from the distal stomach at the time of bypass surgery. It is important to measure the size of the gastric pouch. The tip of the endoscope is initially placed at the gastrojejunal anastomosis, and the centimeter demarcation on the endoscope is recorded. The endoscope is then pulled back to the gastroesophageal junction, and again the centimeter demarcation is recorded. The pouch should contain a volume of less than 30 milliliters and should span approximately 3 to 5 centimeters in length. The gastrojejunal anastomosis should be roughly 12 millimeters in diameter. If this is smaller and you cannot pass the endoscope, it would be suggestive of stenosis. If it is larger, it could predispose the patient to weight regain. It is important to retroflex in the pouch to better visualize the proximal staple line and look for gastrogastric fistula or other abnormalities. Close attention should also be paid to the posterior jejunal aspect of the gastrojejunal anastomosis, as this is the most common site for ulcerations. The blind limb is then measured, as longer distances can predispose to blind loop syndrome. The endoscope is then passed through the roux limb. It is important to see that no bile is present until the full length of the upper endoscope is passed.
The Roux-en-Y gastric bypass has traditionally been the most commonly performed bariatric surgical procedure in the United States. However, this has recently been supplanted by the laparoscopic sleeve gastrectomy. The gastric bypass procedure involves stapling the stomach to create a small gastric pouch. There's then a gastrojejunal anastomosis, and the jejunal limb or the roux limb is connected distally to effect a small bowel bypass. So this procedure has traditionally been thought of as being restrictive and malabsorptive in nature. However, we now understand this actually to be much more complicated, and it likely relies on several gut hormone mechanisms to have its treatment effect. As seen in the accompanying video, the Roux-en-Y gastric bypass consists of a small gastric pouch, roughly 30 cc's in volume, and a gastrojejunal anastomosis proximally. And this is done as an end-to-side anastomosis, such that there is a blind portion to the roux limb that is certainly no longer than 10 centimeters in length, and typically more 3 to 4 centimeters in length. Then there's the roux limb proper, which is typically 75 to 150 centimeters in length. However, some surgeons do make this shorter, perhaps as short as 60 centimeters in length. And distally, there's a jejunal anastomosis, which can also be done as either an end-to-side anastomosis or a side-to-side anastomosis. Now, both of these have hypothetical pluses and minuses. However, it really is pretty much just surgical preference. With time, the Roux-en-Y gastric bypass anatomy can change. This figure highlights on the left a dilated gastrojejunal anastomosis. This anastomosis is originally supposed to be roughly 12 millimeters in diameter, and here you can see it's over 20 millimeters in diameter. In the image on the right, you see a relatively normal gastrojejunal anastomosis. However, this patient had a very dilated pouch. Additionally, the roux limb has been described to contract with time. So they might start with a 100 centimeter roux limb that could contract substantially and become shorter with time as well. So this anatomy is not static, but does change with time, and it's important to make note of this. So that was a fairly typical case of normal gastric bypass anatomy.
So just a quick question. A lot of these patients who we're scoping who have undergone gastric bypass have medical comorbidities and also maybe still obese. How do you approach sedation in the gastric bypass patient?
Certainly, that's an important point. Gastric bypass patients tend to have higher conscious sedation needs, more of a tolerance in many cases. However, I think the vast majority of these patients do fairly well with conscious sedation. Now, if they have problems with recurrent sleep apnea, or if they're severely morbidly obese, BMIs of over 50, or they've had problems with airway in the past, I think that it certainly behooves us to seek an anesthesia consultation and have them maybe involved in the case, or at least get their opinion. However, oftentimes in these patients, you may also be able to do an unsedated endoscopy as well, as long as you provide very good topicalization. So I think in the majority of cases, again, conscious sedation works with good aggressive topicalization, and we reserve anesthesia for